All right, thank you, Susan. Appreciate that. Good evening, everybody, or late afternoon if you're on the western part of the United States like I am. So thank you for joining me. So tonight we're going to talk about utilizing pulse electromagnetic field therapy in the emergency and critical care setting, or PEMF. So I'm going to start off with a case. So we'll start with this case and then we'll kind of wrap it up at the end with this. So this is Misty, or as I kind of her full name, Misty Rosemarie. Misty was a 7-year-old Samoyed cross with a body condition score of, depending on who you ask, an 8 or a 9 out of 9, 41.8 kilograms. She was a hefty girl. So she presented to our teaching hospital emergency service as a down non-ambulatory status. She'd been lame in the left forelimb for a few months, and then she had a dental, and after that was non-weight bearing in that left front. 2 to 3 weeks after that, she was unable to use either front leg, and then kind of collapsed 5 days prior to presentation. So she'd been down for about 5 days before she presented. She had generalized weakness, inability to stand unaided on a floor, and with determining if she had a neurologic component, orthopedic, or a combination of both, it was the kind of the initial conundrum with her. There was initially some pain localized to the elbow region, and she had we get pain score of 2 out of 5. Neurologically, though, difficult to assess her given her body condition and size and just being down in general. Also, not necessarily the most motivated patient in the world. So some of this, we weren't sure if there was a component that way. And she did have some generalized anxiety during her stay in the hospital. So we'll talk about this later, but a lot of vocalizing with her. And we didn't know if that was a combination of anxiety, pain, both, or breed, all those things. So her medications on that presentation, she was on methocarbamol, trazodone, carprofen, amantadine, and had received Librela. So we're going to come back to her as kind of what we did and utilized with her. And she had kind of some interesting response to her PEMF therapy. So learning objectives for this next hour is, I'm going to go ahead and review PEMF. Some of you may already know what it does and how it works, but some of you may not. And so we'll kind of go through a review of that, of how it works. What does the literature tell us it does? What kind of evidence? We always try to practice evidence-based medicine the best we can. So what do we have out there in both I'll go over some of the veterinary studies, but also what do we know from the human side? Because oftentimes we have to kind of draw from that aspect when we don't have as many studies in our field. How can we apply PEMF then in the critical care, ICU, ECC, emergency critical care setting? And then what are some of the best methods and recommendations that I can give for how you could potentially utilize that? And you may be, I'm at a teaching hospital with multiple specialties and an emergency critical care ICUs. We have that available. So we have a lot of variety of patients that come through and that service. So we can kind of see everything. You might be in a private practice where you also see a variety of things, right? But maybe don't have a dedicated ICU, but you're still going to see emergency patients, right? And you're still going to have those post-op critical patients and things like that. So this can apply to any of those scenarios, right? So what is PEMF, right? So PEMF devices can be used really for a variety of purposes. Their initial, though, main therapeutic use was for the enhancement of bone or tissue healing and pain control, which is still what we use them for, but we can look at, there's a lot of other potential uses as well. So these devices were first introduced in the 70s, and then they got approved for FDA approval in the 80s, initially as bone growth stimulators. And so they were used for delayed slow healing fractures in general. So electromagnetic waves can activate a variety of signaling pathways, which we're going to talk about, to reduce inflammation, increase blood flow, and facilitate healing. So we can consider these, we can call them non-thermal, non-invasive, non-pharmaceutical, anti-inflammatory devices. We always like to give acronyms for things, so NPAIDs. It's kind of a nice term to use for these. And when we look at this, so there is this concept of Faraday's law of induction. And this states that a time varying or pulse electromagnetic field will induce an electrical field or electromotive force in a conductor, like a tissue, right? I know the picture might be a little blurry, but that's kind of demonstrating what that is. And differences in waveforms influence the electrical field that's stimulated in the tissues. So electromagnetism is generated by running an electrical current through a coiled wire, and this is our electromagnetic induction. And then these devices are usually then in such that usually a loop with this device, the propagator of the electrical pulse, and then a coil wire that makes the ring to create your magnetic field. And those are then there's loops, there's beds, blankets, etc. Different devices of ways that you can then utilize this. And so it's really hypothesized to have more of an electrical rather than a magnetic effect on the tissues. When we go into what it does again, I found this graphic that I thought actually really summed up a lot of what we know. There's some things maybe we don't fully understand. We're going to talk about what we do know about what PEMF does. So PEMF waves can penetrate all different types of tissues. So calcium, the big thing we're going to look at here is, and my little laser pointer out here. So calcium here. So calcium is binding is voltage dependent, and PEMF then stimulates an increase in calcium to binding with calmodulin. So this calcium calmodulin right here. And that in turn then catalyzes the release of nitric oxide. So nitric oxide then increases or activates our cyclic GMP. And then the effects of this kind of come through all here, and you get vasodilation and increased circulation. You get decreased inflammation via a reduction of different pro-inflammatory cytokines, and then increased angiogenesis. They see elevated levels of the vascular endothelial growth factor and FGF, and then other growth factors also that are involved in granulation and remodeling. Turn my pointer off. Always the fun part. So what else does PEMF do? So those are the main things that we look at, but we've also seen other effects include an increase in heat shock proteins, and these can have a cytoprotective and anti-apoptotic effect, an increased expression of adenosine receptors in tissues, in a variety of cells and tissues, and that then causes a reduction in prostaglandins and inflammatory cytokines. And then an increased expression of bone morphogenetic proteins, and those play a role in our bone and cartilage formation. So we know kind of now what PEMF is potentially doing and how it works. What do we know out there for our evidence? What do we have? And so I thought these three studies are the more recent studies that we have, So there was a 2021 pancreas study with the Calmer loop. So this was a randomized, placebo-controlled, prospective clinical trial evaluating the efficacy of the CC anti-anxiety device, the Calmer canine, for the treatment of separation anxiety. And we had 40 dogs in the study with moderate to severe separation anxiety. And they saw a significant reduction in negative behaviors by week 6. And then a higher percentage of success at week 4 and 6 across the full study. Right. So that's one of the first studies we've seen looking at in dogs, at least using it for anxiety. We'll come back to what we've seen on the human side as well. Then we have the 2019 Alvarez study, the effective targeted pulsed electromagnetic field therapy on canine and post-operative hemilaminectomies. This was a double-blind, randomized, placebo-controlled clinical trial of 53 dogs. And these dogs received PEMF therapy following post-op hemilaminectomies and demonstrated improved wound scores at 6 weeks, and also a reduced mean number of owner-administered pain medications compared with the control group. And then lastly, the bottom one here, so this is a 2017 Zydan study. This was a smaller study with 16 dogs, and they were looking at the effect of electromagnetic fields on post-operative pain and locomotive recovery in dogs with acute severe thoracolumbar intervertebral disc extrusion. So this was a randomized, placebo-controlled prospective clinical trial. And what they found was that PEMF reduced the incision-associated pain in these dogs. And based on their results, and this was only 16 dogs, so we kind of need a few more, but they were seeing that that it may reduce the extent of the spinal cord injury based on some biomarkers they were looking at, and also enhanced proprioceptive placing. So we do have some studies to support looking at utilizing this here, at least for anxiety, and then with hemilaminectomies post-op. So what else is out there? And we're going to talk about a few more of these and some other things too, but just wanted to bring a few of these up, kind of thinking about how I would maybe utilize these as far as our critical emergency patients. So in a rat model of a cerebral insults, they did see that PEMF reduced tissue hypoxia, blood-brain barrier degradation, and neuronal necrosis by modulating the cerebral blood flow at high intracranial pressures. So they said that it could be potentially an effective treatment then for high intracranial pressure after severe cerebral insults. In patients with shingles, they saw a decrease in the neuralgia that goes along with that. For lumbosacral and cervical spine pain, there actually are FDA-approved devices for this in the human as well. And there's been multiple systematic reviews that show a reduced pain intensity and better functionality in patients that had PEMF for these conditions. In a rat model of rotator cuff injury, they did see improved tendon to bone healing. And then in a lipopolysaccharide-induced septic shock in mice, they saw reduced shock in those guys when they induced it in this case. So interstitial cystitis, we're going to come back to this one, but there is a case series looking at it being utilized, PEMF being utilized pain management for interstitial cystitis. So we'll come back to that a little bit when we talk about our cats. And then osteoarthritis. So there have been some animal studies in this. There's one dog study that showed some benefit, although it needed to be, didn't really have a control group as much. But we have seen other studies, including human and lab animal, that by the release of those bone morphogenic proteins, that PEMF may regenerate cartilage by increasing the degree of proliferation as well as the degree of maturation of the chondrocytes, thereby helping to prevent that subchondral bone destruction. And in vivo studies have demonstrated that PEMF enhances the expression again of those adenosine receptors in the chondrocytes in synoviocytes, which helps modulate nociception in the inflammatory processes. So there's other things out there, but this was just kind of a start of what we can find when we search the literature. All right, so who are our critical and emergency patients, right? And I just put a few things up here to kind of remind us. I mean, it can be anything, right? This is definitely, there's way more than this, but everything from your down dog, right? Your acutely down, Frenchie, I could have put a dachshund in here, whatever, but you've got that. You have your hit by car, trauma. We've got some potential respiratory distress at the lower half of the screen here with our bulldog. And then, of course, our blocked cats, right? So these are definitely ones we're going to see. And there is, of course, a plethora of other things that can come through the door. So when I started thinking about how I have used this or ways that I think we could use PEMF in an emergency critical care setting. So one, I want to make sure and emphasize that this is a part of the management protocol along with your conventional care. It's not to really replace anything you're going to do standardly. We still need to do all those things. Again, just like most of the things in veterinary medicine, multimodal works the best. And so this is to really enhance and improve your outcomes, as well as, helping to, one, control, say, pain, especially. A lot of these involve pain, and get them, stabilize and home sooner, right? So something we can potentially look at for that. So pain being one of them, and all the different things that come along with that, which we'll talk about. Preoperative and postoperative patients, they may be in the critical care setting or ICU before they go to surgery and then coming there after surgery. So pre and post-op. Our down patient, right? So there's a variety of reasons, of course, they can be down. orthopedic, neurologic, metabolic, you name it. We can look at, there's things that maybe we can look at there. Trauma, right? That can kind of fall. Some of these categories, of course, cross over with each other. Wounds, burns, and edema. Respiratory cases, talk about maybe some thoughts there. Cystitis or urinary blockage, and then anxiety, how that plays into this as well. So when we look at pain, right? This again PEMF could be utilized as part of your multimodal approach to pain management, whether that's acute pain or I deal with integrated medicine, a lot of chronic pain, right? And many of our critical care emergency patients are experiencing some degree of pain, stress, and anxiety, right? So stress does not necessarily cause pain, but it can change our pain and influence our pain experience, right? And so we can see either a stress-induced hyperalgesia. We can also see a stress-induced analgesia. So it's kind of interesting that we see that. But we do know that pain does cause stress, right? So it can be this vicious circle that we see going on, and then pain and stress can contribute to anxiety, right? And they've even shown in people, and we don't know why it wouldn't be the same way in dogs, animals, people with anxiety tend to sometimes have more likely to have chronic pain syndrome. So there can be, this, again, a lot of interconnections, especially when we look at the neural pathways. So when we look at our patients, we're seeing them, and it could be from trauma cases, post-surgical, but don't forget we've got those animals that could have visceral sources of pain too, right? So gastrointestinal, urinary, brain, etc. And we don't know if some of our patients who are coming to the door may also have a maladaptive pain component from pre-existing conditions or comorbidities, right? So that can then make it that much more difficult for us to control their pain in the hospital. In people, interestingly, there's even a phenomenon called opioid-induced hyperalgesia, where you actually get pain from receiving opioids. And I don't know if we understand that and recognize it as much in animals, but no, that can also happen. So pain is, and there's a lot of things that can go on. It's still something we're still trying to figure out, especially when it comes to what's happening in the brain. What we do know, though, pain can affect all kinds of different things, and we have a lot of different, consequences of pain that can make our patients worse. And so this is adapted. Sorry, it's a little blurry, but this is adapted from the Handbook of Veterinary Pain Management. And I want to also give credit to Dr. Tammy Grubb, as this is from one of the Cs that she's done. But this is just really, I think, really shows how much pain can affect all different areas, right? So we can see here that centrally, it's, central processing changes that lead to anxiety and fear, which eventually can lead to immobilization, which then can affect us, respiratory compromise and diminished pulmonary function. We can get a tissue edema then from being down, but that can also be influenced by the simple adrenal activation, where we get our tachycardia, hypertension, and tachypnea. We also activate the renin-angiotensin release. That's going to cause vasoconstriction, also platelet aggregation, increased risk for thromboembolism. You see all these different things, right? Don't forget about our neuroendocrine changes we see. So increased cortisol, catecholamines, hyperglycemia. This is going to lead to immunosuppression, our increased risk for infection. And then we have impaired wound healing, right? So all of these things can be consequences of pain, and why we really need to take that seriously. So when we look at our pre and post-op care, right? So our goal, whenever I look at why I want to pick and utilize certain modalities or medications, even anything, is what's my goal, right? What's the problem? What's my goal? What am I trying to treat? So again, I'm looking at it as reducing inflammation, reducing pain, decreasing edema, and enhancing healing as well. So most of the time I'm working with our orthopedic and neurologic patients, right? So fractures, cruciate repairs, arthroscopy. For the neurologic cases, could be surgical, could be medical management, because those disc disease, but also the more vascular ones, the cartilaginous emboli, the ANPEs. But this also can play a role in when we talk about wounds and things too. So soft tissue, right? Soft tissue surgeries. So any kind of thing that way, it may play a role. And if we think about the pre-op, like it's very easy to think about, okay, what do we do post-op now, right? What do we do to help decrease pain, decrease inflammation, edema? But what about pre-op? So while we're waiting for our patients to stabilize to be able to have surgery, in general, we know that if we can decrease pain in our pre-op patients, this is going to help with decreasing our anesthetic needs as well as our intraoperative pain management and help us with a more successful post-op pain management. It's been shown good preoperative pain management helps with post-operative pain management, right? So I think it's something and I admit I'm not as good about thinking about this either, but thinking about utilizing some of our modalities for pain preoperatively, right? To get things hopefully set up to have a better outcome in the long run. So thinking about that. And we'll talk about ways too that we can, one of the advantages of utilizing PEMF is that this can be kind of sometimes a more hands-off therapy, which can be very important when we talk about some of our patients that are having like respiratory distress or they're fractious and they're anxious and they don't, you can do you need to do minimal things with them. This is a more of a hands-off treatment is utilizing PEMF. So what about those down dogs, right? And so using the term down dog, but really talking about any animal, not just dog, but down patient. So animal that is recumbent or progresses to recumbent cannot get up and mobilize due to a variety of conditions, right? And we know that there are a lot of secondary complications of prolonged recumbency. So the things we think about, and some maybe we don't think about, but think about decubital ulcers, beyond maybe a little sooner before we get to the decubital ulcer stage, just general dermatological issues that can happen and irritation from them soiling themselves. Oftentimes they're stressed and get diarrhea in the hospital. And so, yes, we're cleaning and yes, we're doing things, but still it happens, right? And then you have, tissue, your tissue integrity of your skin is breaking down. Decrease in circulation, which is going to lead to a lot of different things, but one of them being you start to get some dependent edema. Pulmonary complications then, right? Atelectasis, pneumonia, all those things. So that is a big concern. It's a really big concern in people that are hospitalized as well. Being non-mobile increases pain, right? They're going to get worse being non-mobile. And especially if we're dealing with an older patient who has arthritis, right? So if we have an arthritic patient who's now immobile for another reason, their arthritis is going to get worse. And so you're going to have this now, you've got your acute pain problem or your acute problem, but you've got a chronic and it's getting worse and you can have acute on chronic. And then just not being able to move around and being in hospital, guys get depressed, right? They get down. And that I think definitely does contribute to how, getting them out of the hospital faster can help with recovery. Generally, we just don't do as well, animals and people being in a hospitalized situation, right? So we know with prolonged immobilization, there's a lot of effects that can happen on our tissues. So one thing we definitely know is that unused, and then humans, anyways, these are from human studies. So unused muscle loses strength and atrophies at a rate of 12% per week. And studies have shown that you can get 15% loss in muscle within a week of bed rest and almost 50% loss after 3 to 5 weeks of bed rest, which I think is just insane. Also, contractures of connective tissue. So we get decreased flexibility of our connective tissues when they're not been moving, and this can lead to contracture. And that can begin as early as 8 hours after the onset of reduced mobility. And this then is what contributes to being stiff and sore. But eventually you go long enough and you can get to an irreversible state of contracture, which is further out, but can happen. And then decreased bone density. So in people, bone mineral density, they show is decreased by 1% per week of bed rest, right? So, it's no surprise sometimes then while we always talk about, you need stress on tissues For healing, we need those forces. Well, if we're not moving or doing anything, our bone density itself is decreasing as well. So patients that don't use their limbs well, right? If they're not putting forces on that with Wolff's Law, they're not going to heal as well because they're not having those forces, and there's not that gravity. You need that force of being up. So recumbency care, this, a lot of different parts go into this. Adequate clean bedding and padding, right? So making sure we've got them well padded and clean bedding at all times, rotating them often. If they're wanting to be in lateral, let's make sure we get them in sternal, especially for those lungs, right? And helping with that, with pulmonary circulation. Passive range of motion and massage. I can't harp on that one enough as a rehab person, but any animal that is down for a prolonged period of time or cannot move for various reasons, we should be doing some amount of passive range of motion and massage to help, again, try to prevent this decreased flexibility of these connective tissues, right? Especially if you think about our arthritic patient, but really any patient. This also helps with circulation in general, improving circulation. Environmental enrichment. So we talk about, can do passive range of motion and massage, but getting these animals just up, right? Getting them up, getting them outside if you can. We get them up and we put them over physio rolls and we, different things that way just to get to do things with them. But that in itself is going to help with circulation. And again, it's also stimulating the mind at the same time, right? They get bored. Adequate nutrition, monitor your ins and outs, and then of course your pain management. So your pharmaceuticals, absolutely, need to be using those as appropriate. But what else do we have, right? So I'm going to reach for using my PEMF. I've got my PEMF. I've got photobiomodulation. So my laser therapy, acupuncture. I have a lot of different things and modalities that I can use in addition to help with pain, and PEMF being a part of that. All right, so trauma. So when we look at trauma, the goals, again, of our therapy with PEMF in this case is going to be to decrease our pain, decrease our inflammation, and then wound healing and incisional healing in general, if you've got that as a component. So again, this is from Handbook of Veterinary Pain Management. I thought it was just important to bring up and look at again that this is a schematic of the immune response to trauma and stress. So we know that trauma, pain, and stress results in a multitude of hematological and immune-mediated responses that then can provoke and lead to support that systemic inflammatory response syndrome and eventually lead to the development of multiple organ dysfunction syndrome, right? So by us helping decrease pain and manage the inflammation and thereby hopefully decreasing stress, we're decreasing the chances of developing SIRS and MODS, right? So sometimes you've got these trauma animals and they're fractious, they're uncomfortable, they're nervous, their pain's making them more aggressive, all those different things. And PEMF's another way we can use, again, minimal contact to be giving another way. While of course they usually got their IV on board, you've given them, some sedation, some drugs, and anti-anxiolytics. But also this is something else we can be doing where maybe I wouldn't be able to get in there and do acupuncture or laser, but, and maybe you can't even touch them to do, in this case, it's not time to do passive range of motion, like we can't do that, but we might be able to get them on a PEMF bed or we might be able to put a loop around them. And then the nice thing also is that we can use our PEMF over bandages and casts. So we don't have to remove those to get to the area to treat, which is actually very, very beneficial. So for wounds, burns, and edema, there has been demonstrated efficacy in human studies for incisions, diabetic wounds, pressure ulcers, and burn victims. Remember back to that Alvarez study I mentioned where the post-op PEMF-treated hemilaminectomy dogs had improved wound scores at 6 weeks compared to the control group. So we know that this can help enhance healing. It can be utilized along with your topical therapies and bandages. And so most of the studies do support, and we're going to talk about some of these studies here in a minute, that it's probably most beneficial in the acute healing stages. So us starting this in, right there in the critical care emergency setting is going to be even, more beneficial because it's really going to help the most of these acute healing stages. But there is evidence to also support helping with chronic wounds as well. So when we look at, we've seen accelerated early wound closure, and they've seen increased tensile strength, promotion of tissue remodeling, and collagen synthesis, epithelialization and fibroblast migration, and then enhancing cytokines involved in the anti-inflammatory response. 50%, when we look at pressure ulcers, 50% of lower stage pressure ulcers healed completely or improved compared to none with placebo in trials. They've also seen inhibition of Staph aureus in infected wounds. In studies with burn victims, they saw increased levels of vascularization and epithelialization compared to controls. And then in regards to chronic wounds, there has been shown to be a decrease in inflammation through both intracellular and extracellular effects by, again, reducing inflammatory cytokines, inhibiting the expression of some of the matrix metalloproteinases, and upregulation of nitric oxide synthase, while simultaneously downregulating COX-2 and PGE2 expression. So definitely something we should be utilizing more in wound healing. So what about respiratory, right? So this is currently one of my favorite patients, Miss Olive. As you can see, she has an CC loop around her neck there, and she's actually getting laser too at the same time on the back end. So we're kind of doing a little multimodal therapy at the same time here. So Miss Olive not only has early laryngeal paralysis, she also has had, she's much better now, cervical pain on top of cruciate disease and all the things that labs like to get. But so when we look at our respiratory patients, then this is something we can potentially use on them. And if you're interested in learning more about utilizing PEMF in LARPAR cases, so laryngeal paralysis cases, Dr. Matt Brunke did a really nice webinar recently, just like in the past, I think, month or so, for Zomedica, and you could go watch that through the Zomedica University, but I recommend it. So we've been starting to utilize this on our LARPAR patients when they're in. So they're doing other treatments, and we'll just throw the CC loop around them while they're getting their other rehab treatments that we're doing with them. So when we look at our respiratory distress patients, we know that sometimes less is better as far as handling goes, right? So these guys, again, this is adjunctive use in addition to your standard therapies, right? But think about that animal that comes in. So I'm going to use the case of, you've got the Frenchie who has suddenly gone down. They're in pain. They can't move. That always makes animals anxious and worried. And also, we can't breathe well because we're Frenchie, and we may or may not have had corrective surgery, BOAS surgery. So we add all those things up, and we now have a respiratory distress patient who we can't do anything with until we get that under control, because that's got to come first, right? So we're going to support of care until we can get pain under control. We get them breathing better before we can look at imaging, surgery, however we're going to treat, right? So the nice thing is sometimes you get these guys in the oxygen cage, and then we don't want to we can't take them out. They're oxygen dependent, right? What are we going to be able to do? What can I do in there? But I've had these cases where I want to go in there and do a therapy, and again, I can get my CC loop in there. So I get my CC loop, I can put it around the neck, I can put it around the back, and I can use it as a treatment, but not have to be taking them out of that oxygen cage. They can still receive that, right? So think about it for your LARPARs. Think about it for potentially like swelling, of course, or trauma in the laryngeal tracheal region. Maybe asthmatic cats. I haven't tried that yet, but I don't know why we couldn't give it a go. And then brachiocephalic breeds, right? And things that can go along with that. Especially if you've got a pain component going along with your brachiocephalic syndrome, that maybe this is something we can use if we want to kind of have a little more hands-off approach. So we talk about, don't want to leave our cats out, because we can definitely use this. I use the PEMF in cats quite frequently when I see them for arthritis and we're doing acupuncture, and oftentimes I'm giving them a PEMF treatment while they're getting their acupuncture. But when we look at our emergency case scenario and they come in, you know, what about our blocked cat, right? That's the one we classically think of. And some cats, or, you know, maybe a lot of cats, especially when they're painful, don't really want you messing with them too much, right? So hands-off approach often has to happen with these guys. The nice thing is, you can use these devices, you can be sneaky about it. So the treatment area of a device, if you're not familiar, so the loop that's creating the magnetic field, it's that circumference, and then it's the radius basically above and below, right? So that is the treatment area, and then the beds have multiples of those discs in there. So you're treating this larger region, so you can stick it under a cat bed, you can stick it under a blanket, under a box, put it under a blanket, put the cat in the crate. I've done that before. Probably put the crate on the PEMF bed. The one thing you do have to worry about, we'll talk about this in a minute, is probably how much metal is around you is going to make a little bit of a difference in the efficacy. But so when we look at what do we have to maybe support using this to decrease pain and inflammation in the bladder urethral region, there was this proof of concept case series in women who have interstitial cystitis or bladder pain syndrome, and they use PEMF for the management of this. And so it was a 4-week, so longer term study, but 4-week treatment protocol. And in that 4-week treatment protocol, that 8 out of 10 patients got enrolled, completed. 7 out of those 8, so 87.5%, had a significant reduction in their pelvic pain at 4 weeks. And they had a significant decrease in their overall questionnaire scores, their bladder pain scores, their daily number of voids, and their nocturnia symptom scores. They also had significant increase in their quality of life questionnaires at 4 weeks. And then when they followed them out 8 weeks post-therapy, there was still 50% of them were still continuing to have significant pain reduction, and there was no adverse events or side effects reported. So I think it's something that, again, could be considered as part of your therapy. As we'll talk about later too, this is something you can then potentially an owner can do at home too, right? So these are devices we can send home. So what about anxiety? We have a lot of our patients have anxiety, and again, pain can feed this. They may come with this already, pre-existing anxiety, exacerbate our pain, and we know that anxiety can decrease appetite, can increase GI stress, it can increase pain, increase fear-related aggression, increase our stress and catecholamines. And by no means does this replace having good pain meds and anxiolytics on board, but it can be used adjunctively, right? And it's safe to use. So behavior and anxiety, mentioned the Calmer Loop trial, right, earlier about the decrease in separation anxiety. Now, granted that they were being treated for 4 to 6 week trial. So we don't know how acutely, but we'll talk about that here in a minute with Misty, how acutely it works. But we also have evidence in the lab animal and human side. So rodents models of post-traumatic stress, they did show reduced anxiety behaviors and increased neurogenesis in the hippocampus. Also in humans, it's been shown that treatment-resistant depression in humans, actually utilizing a PEMF therapy, has shown rapid positive effects and longer-term positive effects in that form of depression as well. So something, again, that we can consider another way of utilizing this. Okay, so kind of went through my thoughts on some ways we can utilize this. That is not an all-inclusive list. There are definitely other ways we can use it. It's just something to kind of get you start thinking about how you might be able to utilize this in hospital in those situations. So how would you go about, what's some of my recommendations anyways for like the best practices and utilization of this, right? So the number one first is staff training, right? So first off, super simple to use and super easy. If you've used them before, especially the CC devices, there's an on button. You can also use that button to turn it off, but these have an auto off button, 15-minute treatment, and it's done. So the beds are rechargeable. The loops are not. The loops generally have a guaranteed 150 uses. And then after that, I've never actually counted mine to know, but they might go longer. But those ones you do end up having to replace. So very little training is needed. The really only thing you need to make sure of is anybody utilizing this and your patients or your owners is a pacemaker. Does anybody have a pacemaker? You don't want an ear pacemaker, that type of thing. But other than that, pretty darn safe and not a lot of other things to know. You don't want to bend the loops in half or anything crazy like that. But the nice thing is you can utilize these as often as every 2 hours if you want. I don't usually use them that frequently, but you can. You can add this to your treatment sheet or your electronic whiteboard. So it's getting done. And I think the nice thing about making sure your staff knows about your techs and your assistants and our cases, I'm trying to make sure students know about it because our students are in here learning too, is that they're, seeing our cases, monitoring our cases all day, and they're picking up on the things a lot of times of, hey, I think this patient, needs some more pain meds, or we're having some issues here. And if they're recognizing those patients where maybe this is going to come into play, they're probably going to be the ones that ask for it more and talk to you more about it. So I think that's a good thing to make sure that they know about it. So bed versus loop, right? Some of the considerations for this. Loops are going to be more localized therapy, right? So I think it's the 10 and 20. I don't know. I only use the bigger one. I use 20 centimeter loop. And that's going to be for more your localized therapy. But you can, we'll talk about how you can utilize that. But think about, do you need to move the patient? Can you move the patient, right? So if you can't move the patient, you might not be able to get them onto a bed, so the loop might be better. Do you need your device for multiple patients? Can the animal just live on the bed, or do you need that bed for somebody else? The bed does give you a larger treatment area, which is nice if you're especially treating, multiple joints. We like the bed, it's great. But you do, for best use, you need to really have them outside of a metal kennel. So especially the bed, because that magnetic field could bounce off that metal and decrease the efficacy. It's not going to harm the patient, but it's just may not have as best a treatment as you could if you had it outside. So think about that. And then I have used it in the oxygen cage. It's okay to use in there. So that's always nice to know. Again, I mentioned our hands-off approach. So you can use vet wrap or tape to get these loops in place. They can fit easily over an appendage. In most cases, unless you've got like a really big head, and I'll tell you, some of our dogs are pushing it, getting it over their heads. You may not be able to get it over the head or neck for that area, but you can still put it on the side. So just kind of keep that in mind. Again, with the bed, you could put it under a box, under a bed. That kennel on top of the bed, whatever you want to do that way. But do watch out for naughty patients. We all know patients like to chew on stuff, and I had one young patient try to chew one of my loops, didn't luckily succeed in destroying it, but we were able to salvage that. But do keep that in mind that maybe it's not completely hands off, but we need to at least be watching them, right? And then of course, this is best utilized in integrating it with your pharmaceuticals and your other therapies and modalities. So I like where we can use this in between photobiomodulation sessions. So in between my laser sessions, I can be using this because I may only be lasering my patient once a day, because maybe I only have time to go treat them with my other treatments once a day, but I can have ICU using it multiple times a day on them, right? Or the students are using it multiple times a day. So I've got other things going on if I can't get in there more than once a day. Treating multiple areas with multiple modalities simultaneously, bigger bang for your buck, man. Just get in there and just try to get everything covered at one time. Time is money, and trying to get this done so we can get to our other patients to treat them. I think this can really help. And then utilizing again why we're doing other things. So I might have a patient that's up over a physio roller or peanut, or they're getting passive range of motion or massage, but we have the PEMF, treating another area at that same time. So we can utilize them together. And then also we can continue the therapy at home if indicated, right? So these devices can be purchased by owners to use at home. The loops, we carry the loops in our clinic to sell and go home with. The beds, I have them order from the company. And if they're looking at a shorter term use, or they want to see what it'll do, if it'll help, the loop might be the better way to go. But if they're in for the long haul and the investment, and they know this is a longer term issue, or may have multiple pets at home that may want to use that, then they may want to invest in one of the beds, as the beds can be recharged. So that is something that you can consider talking with them about too. Okay, so we're going to wrap up Misty, and then we'll have some time for questions. So I will say Misty looks better than this now. I don't have a Misty walking picture. I wish I did. I just have when she was in here the first time. But so Misty ended up, she ended up being diagnosed with bilateral incomplete ossification of the humeral condyles, which normally, if that's going to cause a problem in a dog, happens earlier on in life. This dog, remember, she's a little older, kind of weird, but if we look at her body condition score and we look at the fact that she has been immobile and down, probably mostly like the left one fractured and that caused some of that, or maybe it was bothering her. She also had arthritis in some of her joints and things, did that weaken her bone even more, and then she had this fracture later on. So on presentation, we found she had a chronic incomplete articular fracture of the left humerus. And then 2 days after that we diagnosed that, it wasn't seen on the initial CT, we found she had an acute articular fracture of the right humerus. So we had those things. Now her back end was fine, and neurologically, both the neurology resident and myself felt that she was actually probably neurologically normal, but so hard to determine in her with her size, and again, her lack of motivation and her inability to really want to cooperate with us. But she had bilateral surgical repairs. She was hospitalized for 5 days before discharge. Now, during her stay with us, one of the things about Misty was she was vocal a lot. She was very vocal during her stay, whether this was anxiety, pain, being an Arctic breed, all of the above, I don't know, but she was very, very painful. And one of the things they were asking, what can you do? And so we used a combination of laser therapy. You can see I kinesiology taped her, with acupuncture. She was getting, great recumbency care. Like a lot of people help and work on her, students, everybody, the doctors here, the house officers, everybody, the staff, the technical staff, and she saw pretty much, I swear, almost every service in this hospital at some point when she was here. And she was on, the appropriate pharmaceuticals. But we also said, well, we could put her on a PEMF bed, right? And so we had her on a PEMF bed and the students came and they asked me, hey, how often can she have that? And I said, why? They said, well, that's the only time she's quiet is when we have her on the PEMF bed, and we turn on the PEMF bed and she passes out. And so for the most of the time, anytime she had a PEMF treatment, she would fall asleep and was quiet. And it was funny when she's come back, now she is ambulatory now. We sent her home with a quad cart to manage until she was more ambulatory, but she is ambulatory now. But she has returned for follow-up visits, dealing with some wounds and things. And we did suggest they get a PEMF device. I don't know if the owners did it or not, but one of the things was we'd still sometimes use a PEMF on her when she came back, and she'd just immediately take a nap. It was the funniest thing. So she was one that really made me think about this talk and coming up with this of how we can use this in these scenarios, just because of her case really kind of wrapped it all up for me. But I definitely like using it for a variety of cases, not just that come to me, but also through our emergency service as well.